the epidemic, but obviously very different in many respects as well. So for today's panel, we are looking at Pakistan's responses on COVID-19. There have been many responses and range from initial othering of the epidemic or othering of the infection, where many in our society believe that this epidemic was somehow God's punishment to Chinese people for their misbehavior with the Muslim minority. But then we saw that the epidemic was actually on our borders as well, in our brother Islamic country, Iran. And then gradually we saw that the blame shifted from the infidel Chinese to the irresponsible pilgrims in Iran. So from there, the kind of discourse developed about othering of the disease, othering of the epidemic or infection as God's punishment to something which was amongst us now, and we had to deal with it. So from othering to domestication of the epidemic, owning it and trying to do something. Some provinces were obviously more active than other provinces. There were quarantine centers which are set up in various cities. Emergency kind of arrangements were also put in place to deal with a projected increase in numbers. So governments of various departments came together and helped to build up a response for the epidemic. At the same time, at the social level, there were instances of stigma, instances of othering that continued. And there were also concerns, obviously, from various quarters about the lack of preparedness of the country and its public health system. There were all kinds of vulnerabilities of various segments of society, which also came to forefront and became part of the discussion. So this epidemic then in many ways was similar to other epidemics that we have known and studied before, including HIV. So we start with othering, investigation of the problem later on, and then the stigma and discrimination continues. But this epidemic is also very different from the epidemics that we have known before. It is different in the sense that we didn't have any set epidemiological risk groups, as opposed to HIV, for example, for which we were given templates from other parts of the world where the epidemic had settled somehow and had become a kind of a lived kind of reality. So there were templates from Africa, for example, about risk groups of HIV that we could then import and design our interventions accordingly. So this was due to the nature of the epidemic itself, the speed at which the virus spread, the sheer pace of the epidemic and how it became a pandemic within weeks. And the country responses were obviously developing simultaneously in different countries. So we had models, for example, the South Korea model or the Germany model or the UK model, but these are the models which were developing simultaneously. This was not something that we could get from other countries and implement them in Pakistan as tried and tested models. So one of these models, for example, was that of herd immunity, which was initially very popular with policymakers and politicians in the UK and in Pakistan as well. But then there was obviously a reaction, a very strong reaction against that kind of thinking in policy circles, and people dissociated themselves from the notion of herd immunity very quickly. The other model which was slightly established was the Chinese model of crackdown, lockdowns, which was again problematic for democratic countries because it was seen as Chinese destiny with their own population, which should not be repeated somehow. So initially there was a lot of opposition to that kind of dealing with the epidemic as well. Some people everywhere in the world, in all countries, have seen this epidemic as a kind of a leveler, that the epidemic does not, the disease does not distinguish between people, anyone and everyone, regardless of their piety, their politics, level of wealth, or health status, or personal behavior was at risk. So unlike HIV epidemic, for example, this epidemic put everyone at risk. You didn't have to be a bad person in order to get this infection. So that thinking about this epidemic being great leveler, and we also had some political statements, for example, from the UK Prime Minister saying something to that effect, that this was a leveler, was again pushed back by people who study epidemics, by social scientists, because this is not a leveler. There are different levels of vulnerability that included, and the evidence shows that age, underlying conditions, socioeconomic background, occupation, especially if you're part of the health workforce, it adds vulnerabilities. And one of the vulnerabilities of individuals and groups is their migration status as well. And apart from that, there are obviously also vulnerabilities regarding state action or inaction. So whatever actions the states are taking, actions that states are responsible for, put different people at different levels of vulnerabilities. So that has to be taken into account as well. And there are other very interesting, intriguing responses beyond this. So we have seen the use of religion, for example, these telethons and collective prayers, controversy over gatherings in mosques, so all that, and misreporting, misinformation in media. So like any epidemic, this epidemic is very prolific in producing new, novel kind of social phenomena, social trends, and also repeating some of those which we have seen in times of other epidemics, which can be a subject of social scientific investigation. But in this panel, what we're trying to focus is on the response of the health system, the public health system, and especially in relation to vulnerable groups, which also include migrants. So to that, I would invite now our first speaker, Dr. Arif Azad. So I'll give you a brief introduction of Dr. Arif Azad, although many of you would already know him. Obviously, he's a very known figure in public health sectors in Pakistan. Dr. Arif Azad is a medical doctor with a master's in public health policy and public health. A public health consultant, he has been working in the development and health areas for over 2 decades. Dr. Azad, besides serving as CEO of Network for Consumer Protection, health-focused NGO, has widely consulted for a broad range of development agencies and INGOs, DFID, UNDP, and USAID, and MSF, WaterAid, and SiteSaver. His work experience spans across Pakistan, Europe, and the Middle East, and the UK. Dr. Azad has also regularly contributed to premier journalism publications, including Guardian, BBC, Dawn, The News on Sunday, Economic and Political Weekly, and Tehelka, amongst others. He also worked with MSF on migrant health projects, focusing on stranded refugees and migrants in Greece and Syrian and Palestinian refugees in Lebanon. Dr. Azad is also author of Patient Pakistan, Reforming and Fixing Healthcare for All in 21st Century, which is a collection of essays on health. So without further ado, I request Dr. Arif to give us a contribution for the panel. Arif, you will need to unmute your mic.
Thank you very much, Ayaz, in putting it together, and inviting me for this, in discussion as a panelist. Let me begin with just a snapshot of, where we are now, in terms of cases. Then I will discuss how we got here and what has been the response of the health systems, and whether we were, prepared, or what lapses, in terms of preparations, and a bit of what lessons we can learn from that. As of today, according to National Health Institute, we have 15,759 cases and 346 deaths so far. The highest number of cases is in Punjab, which is about 6,000, and I mean Sindh is not far behind with 5,600 cases, and then KP above 2,000. And then Balochistan about 1,000, getting there, and then distributed between GP, AJK, and Islamabad. So this is just where we are in terms of the situations. Yes, from the beginning, on February 26th, special advisors to the PM on health, Dr. Zafar Mirza, tweeted that Pakistan has reported first two cases of corona. Earlier on, because there was an outbreak in the neighboring Iran, which borders Balochistan, Pakistan had closed its borders, which I think the decision came a bit late because we were aware of the outbreak in Iran. But anyway, border was closed, and Zaireen was asked to remain where they were. And Pakistani government, requested Iran to keep them, but there was some official to and fro over these issues. But ultimately, they had to come back. The waiting of these, travelers was inadequate. I think the press reports and also the anecdotal evidence and the others, suggest that staff at the airports was not trained, and so I think most of the cases, slipped, without being, detected into the general population. So as for the Iran, I think, and also, the third source of infection was the Tablighi Jamaat Ijtima in Lahore, which despite the clamor of all the people and also the administration was allowed to go ahead.